Thank you. Good morning. These are my disclosures, none of which should represent a conflict of interest for the topic we're discussing. I apologize for how quickly we'll have to proceed through the following slides, but we're discussing two very different disease processes, one of which has received a great deal of recent attention. Our first question is, what factors predict the failure of non-operative management or antibiotic therapy for adults with acute appendicitis? 10 years ago, I'm not sure that this topic would have been of sufficient interest such that it would be discussed at a meeting such as SAGE's. And therefore, it's impossible to discuss the risk factors for failure of antibiotic therapy in appendicitis without at least discussing some of the studies that prompt us to ask such a question. The concept of antibiotics as a replacement for appendectomy began in the pediatric surgical population, which is where most of the data on factors predicting failure of that antibiotic therapy remain to be found. There's likely some degree of analogy or crossover between what we have observed in pediatric patients and what we might expect to observe in adult patients with appendicitis, since after all, acute appendicitis is the most common cause for emergency abdominal surgery in both groups. In unselected pediatric subjects, non-operative management fails in 19 to 40% of patients, and those failures are associated with the presence of an appendicolith, appendicitis associated with a small bowel obstruction or a bandemia, and a longer duration of pain prior to presentation, as well as a higher white blood cell count at the time of presentation, with no established threshold or cutoff value for those last two variables. But in terms of this scenario in adults with appendicitis, we actually know less than what you may think as compared to the loose manner in which this subject is often discussed. I believe the following statement is fair to the best data that we currently have. The majority of patients with acute uncomplicated appendicitis can avoid appendectomy through antibiotic treatment during the first year of follow-up. And please note that that statement does not necessarily touch upon concepts of non-inferiority or superior results with antibiotic treatment without first defining our terms. Because even the best studies that we currently have significant methodological weaknesses. For example, you'll have trials that only include open appendectomies and others that have an admixture of open and laparoscopic surgical approaches, even though those surgical techniques are really quite different. You'll have trials that either include or exclude patients with complicated appendicitis, creating heterogeneity within that trial and limiting to a degree comparisons across trials. You'll have definitions of success that are somewhat creative. So for example, defining the efficacy of appendectomy based upon whether there's intraoperative confirmation of appendicitis. Additionally, there's significant crossover between treatment groups, especially from the antibiotic group to the appendectomy group, and this creates wildly different estimates of efficacy depending upon per protocol or intention to treat analyses. And really through all of that, there's very little data in adults about factors predicting the failure of antibiotic therapy. Most of our focus thus far has been on whether we can get away with it. And let me describe briefly what I'm referring to. So this is a clinical trial that was published in the British Journal of Surgery in 2009 that enrolled 202 unselected adult subjects with acute appendicitis. And the authors cited a 90.8% treatment efficacy for antibiotic therapy. But the challenge is that almost 50% of patients in the non-operative group crossed over to the appendectomy group, so that based upon an intention to treat analysis, the efficacy of antibiotics was actually closer to 48%. Further, surgery patients had a higher incidence of generalized peritonitis and a higher white blood cell count upon presentation, indicating that they were more acutely ill. The efficacy of surgery was defined in part by the intraoperative confirmation of appendicitis, which is somewhat of an unusual metric, and surgeries could be approached by open or laparoscopic techniques. Only 60% of the non-operative subjects reached one-year follow-up. This study, published in Lancet in 2011, included 243 patients with uncomplicated appendicitis, including subjects who were known to have an appendicolith. 123 study subjects were allocated to antibiotic treatment, and surgeries could be approached by open or laparoscopic platforms. The primary study endpoint was peritonitis within 30 days, a definition that includes a radiographically demonstrable fluid collection following an appendectomy. In this study, antibiotics were not non-inferior, and interestingly, only the presence of an appendicolith was associated with failure of antibiotic therapy, while probably underpowered. Excluding patients with an appendicolith and a subgroup analysis revealed comparable outcomes between those groups. This highly cited study in JAMA 2015 enrolled 530 patients in a multi-center randomized trial. 27.3% of antibiotic-treated patients underwent appendectomy within 1 year. Non-operative therapy failed to meet the study's predetermined non-inferiority margin of 24%, and in this study, appendectomy patients experienced very low incidences of complications. What's interesting is that at 5-year follow-up, 39.1% of patients initially treated with antibiotics experienced at least one recurrence of appendicitis, which was interpreted by the authors as another proof of the feasibility of antibiotic therapy. And lastly, this well-executed systematic review and meta-analysis in Annals of Surgery 2017 included 4 randomized trials, including those we just discussed, and 4 cohort studies. As I alluded to earlier, the 4 trials demonstrated a high degree of selection and attrition bias. For antibiotic treatment, 26.5% of those subjects required surgery at 1 year. So the effectiveness of antibiotics was 72% versus almost 100% with surgery. Further, complication-free treatment was lower with antibiotic therapy as first intervention, so that in this meta-analysis, appendectomy had superior treatment effectiveness and complication-free treatment success. So one of the unanswered questions that stands behind all of these data is the issue of whether there are different forms of acute uncomplicated appendicitis and whether each of those are equally treatable by antibiotics. In the past, we never broached that question or subject because we simply removed the appendix and the matter was resolved. The truth is we don't know the optimal antibiotic regimen for non-operative therapy for appendicitis. We have trials that include more open appendectomies that would occur in our respective practices. And it's only recently that there's been a recognition of the measurable risk of appendiceal neoplasm with perforated appendicitis, estimated in one trial to be 20% at 1 year of follow-up. Very recent data suggests that in comparison to antibiotic therapy, appendectomy is associated with lower readmissions, fewer office visits, a lower complication rate, and reduced overall costs. And while patient preference studies require an equitable presentation of all of the options, the most recent data from this discipline suggests that most patients would choose surgery, as I believe most surgeons would as well. And so we could agree with a prior statement from SAGES that in terms of surgical intervention for adults with acute appendicitis, the preferred approach is laparoscopy. And we need trials that only include laparoscopic approaches for a valid comparison to antibiotic therapy. Patients being considered for antibiotic treatment should have the same detailed, informed consent process that preoperative patients are provided. For uncomplicated appendicitis, given the data we have, it's probably best to exclude patients with an appendicolith from that form of initial treatment. And for adult patients, they all need follow-up with a surgeon. And if that patient's more than 40 years of age and has perforated appendicitis, they probably should undergo an interval appendectomy to exclude the presence of a neoplasm. And in terms of complicated appendicitis, the data continues to suggest that an initial non-operative management period is associated with decreased complication and reoperation rates. And in my short amount of remaining time, we'll move on to the second question. Thank you. What are the factors predicting the failure of non-operative management for an acute adhesive small bowel obstruction, or SBO? I think most of us recognize we're no longer depending upon this to determine if we operate or when we operate. But it's still a balance because on the one hand, we want to avoid unnecessary surgeries that run the risk of producing additional adhesions and SBOs and that also accrue the risk of potentially unnecessarily broaching complications from entering a hostile abdomen. On the other hand, ischemic enteritis secondary to an SBO has a high mortality rate, and observing that form of an SBO is never appropriate. And through that balance, we hope to reduce lengths of stay and cost by avoiding unnecessary delays in surgery for SBOs that won't resolve without it. A very brief word about transition points. There's an interesting disparity between what most of us were taught about how CT demonstrable transition points predict a higher likelihood for the patient requiring surgery. And on the other hand, a limited amount of data that's fairly evenly split between supporting and contradicting that viewpoint. And so in fairness to what's been published, I'll simply say the prognostic significance of transition points is somewhat unclear. How do we avoid this failure? There's ischemic bowel, but we don't recognize it. Remember, there's a difference between the concept of partial versus complete obstructions and the concept of no ischemia versus ischemia. They're related, but they're distinct. I think most of us, hopefully all of us, would operate in the setting of an SBO with generalized peritonitis. I think most of us would consider immediate intervention surgically for localized peritonitis. Certainly, the higher the white count at the time of presentation, the higher the stakes, although there is still no established cutoff value above which we can approach the idea of ischemia through an algorithm. CT remains valuable because it establishes the diagnosis in the majority of cases, helps to identify an abdomen that might be hostile based upon matted intestine, and also identifies ventral hernias that you and I will be forced to address if we're forced to operate. But when it comes to radiographic findings that are pathognomonic or highly predictive of ischemia, these are the candidates, and essentially these are the best of the worst. It's surprising how poorly performing these individual or aggregate markers are in predicting ischemia, and reduced bowel wall enhancement seems a day late and a dollar short. So you operate for ischemia if you suspect it. The clinical signs alone predict ischemic enteritis less than half the time. Even ominous clinical features have a low sensitivity, and to date there's not one sign or consensus-proven group of features that allow an algorithmic approach, including time of observation. And then very briefly, how do we avoid delaying surgery for an SBO that won't resolve without it? Well, if you aren't concerned about the presence of ischemia, there's evidence to support the early use of a water-soluble contrast enema. If you instill at least 100 cc's of undilute contrast via nasogastric tube, the failure of that contrast to progress into the large intestine after 8 to 12 hours of observation and NG tube clamping highly predicts the need for surgery. There's more data for its diagnostic value than in its therapeutic ability to resolve an SBO. And then lastly, I wanted to just mention this paper because it provides a measurement for something that we've all seen. This study suggested that the presence of more than 3 square centimeters of intra-abdominal free fluid, that's at least of 10 Hounsfield units, highly predicts the need for surgical intervention, not necessarily due to ischemia, but due to a high-grade SBO unlikely to resolve without surgery. So in closing, CT remains a critical imaging modality. Sunset's not a time constraint, but SBOs are still time-sensitive diagnoses. The earlier use of water-soluble contrast studies may cut short an otherwise unnecessarily lengthy length of stay waiting for a resolution that won't arrive. And ischemia, surprisingly, is still a diagnosis of suspicion. Thank you.